Cholesteatoma. So the important questions from this chapter are classification, etiopathogenesis, clinical features, management of cholesteatoma, and theories of formation of cholesteatoma. What exactly is cholesteatoma? It's otherwise also called as epidermosis or keratoma. So the middle ear mucosa is nowhere lined by the keratinizing squamous epithelium. It's either lined by the cuboidal epithelium or ciliated columnar epithelium. So presence of squamous epithelium, keratinized squamous epithelium, or migration of squamous epithelium into the middle ear is what is termed as cholesteatoma. It basically is skin in the wrong place. Cholesteatoma consists of two parts. One is the matrix and the central mass. The matrix consists of keratinized squamous epithelium, which is resting on the stroma or the fibrous tissue, and central mass, which consists of keratin debris, which is produced by the matrix. This is a schematic structure of cholesteatoma. The central part is the keratin mass surrounded by the matrix, which consists of stratified squamous epithelium lying on the fibrous stroma. Moving on to the theories of formation of cholesteatoma, the first theory is the presence of congenital cell rests. Second theory is the Whitmark's theory. According to this theory, the invagination of the tympanic membrane, either from the attic or the posterior superior aspect of the pars tensa, will form the retraction pockets. And now the outer surface of the tympanic membrane is lined by the stratified squamous epithelium, which we already know, and that will be forming the matrix of cholesteatoma. Second theory is the Rudy's theory, which basically is telling that basal cell hyperplasia is what is resulting in cholesteatoma. Now the basal cells which are present in the germinal layer of the skin, they under the influence of infection will proliferate to lay down keratinizing squamous epithelium. Haberman's theory states that the epithelium which is lining the external auditory canal or the outer tympanic membrane, the outermost layer of the tympanic membrane, will migrate into the middle ear cavity via a pre-existing perforation, especially the marginal type, which is present along the margins of the tympanic membrane and also cause destruction of annulus. Sage's theory tells that it is the metaplasia of the middle ear mucosa because of repeated infections, which is going to cause formation of squamous epithelium. Moving on to the classification of cholesteatoma, we have congenital cholesteatoma, acquired primary cholesteatoma, and acquired secondary cholesteatoma. Congenital cholesteatoma usually arises from the embryonic epidermal cell rests, which are either present in the middle ear cleft or in the temporal bone. The most commonest sites where you can see congenital cholesteatoma is the middle ear, or the petrous apex, or the cerebellopontine angle. So depending upon the site, the symptomatology varies. Middle ear congenital cholesteatoma will present with a white mass behind the intact tympanic membrane and this conductive hearing loss as well. Usually this will be found on a routine examination or on myringotomy. So also it can rupture, the tympanic membrane can rupture spontaneously and present with discharge, and you cannot differentiate it easily from the chronic suppurative otitis media. Primary acquired cholesteatoma. Now in this we call it primary because there is no previous history of otitis media or no history of a pre-existing perforation. So either there is eustachian tube obstruction, which is creating a negative pressure in the middle ear because of which there is a retraction pocket which is formed either in the attic or the posterior superior part of the pars tensa, that is causing primary acquired cholesteatoma, or because of proliferation of basal layer or basal cell hyperplasia or metaplasia of middle ear mucosa because of underlying infections of middle ear. These could be the causes for primary acquired cholesteatoma. Secondary acquired cholesteatoma is called so because there is already a pre-existing perforation in the pars tensa. It's either associated with a posterior superior marginal perforation or sometimes a large central perforation. Now, what are the theories which state about how a secondary acquired cholesteatoma occurs? Maybe there is repeated infections which is resulting in metaplasia of middle ear mucosa, or there is acute necrotizing otitis media where there is a large central perforation or a marginal perforation which is formed, and through this perforation there is migration of the epithelium into the middle ear cavity. Once the cholesteatoma enters into the middle ear cleft, it can invade the surrounding structures and cause enzymatic bony destruction. It has the property to destroy bone. It may cause destruction of the ear ossicles, the erosion of bony labyrinth, or the canalofacial nerve, sinus plate, or tegmen tympani, and this might result in several complications. Bone destruction happens by various enzymes, that it could be collagenase, acid phosphatase, proteolytic enzymes, which are liberated by the osteoclasts and mononuclear inflammatory cells, which are seen in association with cholesteatoma.